condition that I'm sure when we get back home tonight, we start finding out from ourselves what is happening to us. Let me now open this forum for questions, comments, and discussion. Questions, comments? Thank you.
I will go there. Yeah, no problem. Thank you.
First, I'd like to congratulate Professor Hariharan on a very, very interesting talk. I have to say, I thought the pan music was absolutely enthralling. And the fusion of the music you chose with the instrument is something very powerful. So no excuses for that.
Thank you.
And before I get into the serious stuff, I have to say one more thing about the end of your lecture. That if you want to find some group of health professionals that is held in even lower esteem than your anesthesiologist, just turn to us, all right? When I was working here for 6 or 7 years, one of my very senior colleagues in surgery, we were at some function talking socially, and he turned to me and he said, "Tell me, what it is you do?" so you're still a little ahead of us. The serious point though is this, I mean, the things you spoke about are very close to my heart, and I know that a lot of the patients who come to you in that futile state come from us.
Yes.
But I feel that the issue is in a very big way, a philosophical issue. It's a philosophical issue about what we mean by the quality of life and the relevance of death. You know, many, many years ago, when the whole idea of, when health economics took on this idea of quality of life, and they started to create tools like quality adjusted life years, it was kind of bizarre to me that when all of that started, the lowest denominator was death. So when you score, once you were alive, as far as they were concerned, it was better than death.
Yeah.
Now I know they've moved on from that, but it took them a long time to move on from that. And I think that that overriding philosophy now drives our motivation as people who work with life and death every day. And I think that philosophy is so inherently flawed that until we can change that, we are going to have a battle on our hands. And unfortunately, I think you touched on a really important point with regard to where that is taking our non-medical population. So we started the problem in the way we think about what we do, but now our population has bought into it. Yeah. And as you rightly said, we made the mistake, but we have the knowledge to understand the mistake. We have sold this mistake to people who don't have the knowledge to deal with that information. But I want to say that when we have patients that fall into that category of futility in our department now, it is much more common for us to enter into a discussion with the patient's relatives. And we do have some success in getting to an agreement with the patient's relatives that maybe it's time to think about letting nature do the right thing. And we have had some success in that. Maybe not as much as we should.
Thank you, Dr. Sami, and I have to acknowledge that fact because whenever I am on call and if Dr. Sami is on call, we talk, and then the patient I told you, I spent 1.5 hours explaining the reality to the patients in the emergency department, and Dr. Sami reinforced that, and then they agreed not to do anything. This was a young person with a cerebral hemorrhage.
Professor Hari, I really want to congratulate you on a very thought-provoking and wonderful lecture.
Thank you.
I believe it was Tennyson who said, "Death is the end of life. Why should life all labor be?" And today, I think you've answered it. We should labor in life so that we can pay for death. Because death is expensive. I never found the answer until today. So this is very enlightening to me. But another interesting thing is that you quoted about 75% of people now die in hospital. I think there was a survey in America in 1910, so it's almost exactly 100 years ago, when 10% of people used to die in hospitals and 90% died at home. And we are approaching the level where we almost have a reversal of the ratio. So maybe the news we must spread is that people now come to hospital to die, not to live. But the last thing is, and this is now of public health importance, I have found some success in persuading people to die at home. If I have somebody who has, say, terminal cancer that really has not responded to anything, I find if you spend some time explaining to them that it is more merciful to die at home and with more dignity, and that in fact Limacol and prayers is cheaper than an ICU, they would buy that.
Thank you, Prof. I mean, that is what, I mean, actually, I think, when the university professors have a similar thing, I think we need to impart this to the younger generation, and, they all have to, understand the same thing. I mean, Prof, with his experience, he can talk and convince, and that is what we have to learn from, how to effectively communicate to the patients and make them realize that, I mean, this is not the best option for you.
What's your recommendation with regards to euthanasia, the mercy killing, euthanasia?
No, that is again very highly philosophical, this one, I mean, it is a very controversial issue. I mean, and again, it has to be, in the context of where it is being practiced, because, something, there is now like health tourism, there is suicidal tourism. That, I mean, people go into Switzerland to actually have euthanasia done. They don't want to live, so they go into Switzerland to die. And this is being practiced now, actually. So what I'm trying to tell you is it's a lot of cultural contextual difference. If I support euthanasia now, it will be very, very blanket thing to say. All that I wanted to say is that, there is a clear distinction between the concept of medical futility and euthanasia, because many people confuse both the things. Common public, when the patient surrogates come to us and say that, I mean, see, when we say that we are going to withdraw support because patient cannot make it, so is it euthanasia? So you are going to actively, enhance the process of death. That's what they think. But euthanasia, by definition, is the healthcare worker should be an active instrument responsible for the death of a patient. Active process, not a passive process. Withdrawal is a passive, act of omission rather than act of commission.
Yeah, that's what exactly I wanted to tell.
Yeah.
This another thing is, are there any studies done whether euthanasia is in a different situation required or not required, or is it a must or not, like that?
No, euthanasia, I don't think, I mean, anybody has, advocated euthanasia. It is only individual physicians and case. I mean, it is nothing like, I have never seen any in ethics, medical healthcare ethics literature, actively, studies actively pronouncing that euthanasia is the best way to go. There is nothing like that.
Yes.
I have one statement to make. We were asked by the chairman at the beginning to speak the truth, that we should all leave with the truth today. Harry, I came here not with the intention to praise you, but you have not told us the truth. This was not a lecture. This was a symphony. And you are not a tabla player. You are an entire orchestra. Congratulations.
Thank you.
Questions, comments?
Professor Harry, thanks again for an excellent lecture. I have a question, and the question is, how do we then change the conversations that we as physicians have with persons who are the representatives of patients facing the end of life in a futile situation? Because it may seem obvious to the physician, knowing that this situation isn't going in the direction where the patient is salvageable. But do you know of any sort of templates, guidelines, best practices for how you have a conversation of this nature? Because it's going to be very operator dependent if you leave it to individuals with their own backgrounds and life experiences to decide how to tell a relative, hey, what, see this man? He going through. Don't bother about it. So, I mean, how do we do that? Where's the sensitivity, training, and those sorts of things that would be needed to get that kind of conversation to happen in a way where we don't end up in the newspaper every day for being the insensitive healthcare bastards that we are usually called? That's really my question.
Yeah. Actually, you touched a very, very important point, Avery. Actually, I mean, that is what I meant as effective communication, because, you know, I can have those algorithmic approach and protocols, and I am one person who I don't believe in protocolized medicine. I do not like protocolized medicine, because you don't need to be a doctor to be to follow some protocols. You know, you can be a technician and to just do whatever is there in the protocol. You know, protocols are not going to help, and that is where I said effective communication and learn from role models like Prof Hariharan saying how, I mean, if an intensivist is, if Dr. Parkinson is going to have a discussion with the patient surrogates, I would say that the students have to accompany and see the role models, how they are effectively communicating, and I mean, touching those sensitive aspects of, you know, because as you rightly said, this man is not going to make it. That is not the way we are going to say that. You know, I mean, like how we initiate the discussion and how we win the confidence of the patient relatives that we are actually caring for the betterment of the patient. And we have done that, and I know Dr. Sami has done that. I have seen him doing that, and we all do that, and that is what I was saying, that our residents and the junior doctors have to, you know, practice and practice and practice, and that is how it comes. And because that is a human relationship, and as you said, you know, that no protocols and no guidelines and no algorithms will help you as a blanket thing, you know, because as I told you, it is different in different regions, how to initiate discussion with people. I cannot do the same thing in US. They will sue me. You know, I mean, so that is a lot of difference actually. So there's no single answer to that anyway. But as you said, you know, I mean, we all have to learn the effective communication. Yes, Dr. Sami.
You know, having said that, we underestimate what our patients want. I think we walk into those conversations thinking that our patients want us to do everything to make their relatives better. And in fact, usually our patients are on the same wavelength as Prof was saying. Our patients' relatives are not stupid. They're looking at their relatives dying, and they just need someone. They just need somebody to say, you know, this is not good social. I think, I have to be honest, I'm saying I think, you know, but I think. No, what we are doing, you have to be honest. I think a lot of what happens is that people with less experience are so afraid that the relative has this preconceived idea, I want my relative to live. I don't think that's not.
I think this conversation will continue when we go for the refreshment, but I want to say that I will let the university know that our professor has professed, and this is what he has professed. Die at home in the arms of your family and the dignity of your own environment instead of at the industrial complex of ICU, where the only touch you get is machines and machines. On that note, I want to invite Dr. Bob to give a vote of thanks, and this discussion, as I said, will go on during our refreshment. Dr. Bob, please.
Thank you. We have to go wait one day.
Good night, distinguished guests, colleagues, ladies and gentlemen. On behalf of all of us in attendance tonight, I would like to thank Professor Sitaraman, firstly for his lecture and the insights that it has brought to us today, and secondly for his wonderful pan melody. Most successful men have not achieved their distinction by having some new talent or opportunity presented to them. They have, in fact, developed the opportunity that was at hand. I first had the opportunity to conduct research with Professor Sitaraman as a medical student. This was a unique opportunity. A 2-month July-August research project under his guidance yielded 3 published papers in peer-reviewed journals on anesthesia and critical care medicine, 2 of which my fellow students and I were listed as authors. We grasped the chance to present our findings at the Caribbean Health Research Conference and the Trinidad and Tobago Medical Association annual meeting the following year. I would like to emphasize we were only year 2 medical students. This was, in fact, a great feat. Are there opportunities available? Yes. But success depends on how you use them. Research is a tool that can be used to make great medical advances. Professor Sitaraman taught us about hard work, efficiency, thoroughness, and good research analysis. All of these qualities, which he has demonstrated here tonight in his research, have been imparted unto us, and we have all moved forward as clinicians and solid researchers. As postgraduates, he continues to support us, even those of us not under his direct care and anesthesia. From all the students, I would like to thank Professor Sitaraman for sharing his time and knowledge with us. We would like to thank Professor Rhoda Raddock, Acting Campus Principal, for the great support given from the campus. Professor Samuel Ramsawak, Dean of the Faculty of Medical Sciences, for that wonderful introduction. Professor Jacob Opadei, Ms. Patricia Sampson, and all staff members of the Open Lectures Committee for organizing this wonderful event tonight. Professor Vijay Narayan Singh, University Lecturer, for all his support and continued encouragement. Dr. Derek Chen, for support in the Department of Anesthesia and Critical Care as a fellow lecturer and as a friend. Ms. Venetia Bash, the editor of UE Today. Mr. Narendra Ramsubag, past president of the Bluebirds organization, PINAL, for his support, as well as for the pepper rotis we will be consuming tonight. To all students, and I'm quoting Professor here, who have been the backbone of my career, unquote. It indeed has been an honor to give this vote of thanks tonight. Thank you all for your attendance. It has been indeed a great, great pleasure. Good night.